Elia. Oh, you want the actual name? Tell me the issue.
Because you cannot tell pelvis. Supposed to tell bony pelvis. Okay? Is it clear? Yeah, thanks. Then how do you hold it in anatomical position? They will ask when you go to gynec department, they will ask you to hold it in anatomical position. How the pelvis will be in anatomical position. How will you hold it? How will you hold it? So if this is a wall, if that is a wall, this is the anatomical position of the pelvis. This is how it will be. What did I do? The anterior superior iliac spine and pubic tubercle. Anterior superior iliac spine and pubic tubercle should touch the horizontal. Is it clear? This is how it will be in the body. This is how it will be in the body. If somebody asks you to hold, you should see that anterior superior iliac spine and pubic tubercle should touch the plane surface. Is it clear? That's clear, isn't it? Next they will ask, I did tell you in the class to read about the types of pelvis. Types of pelvis. Did you have 5 minutes to see that? At least 5 minutes? What are the types of pelvis? Android, gynecoid, anthropoid, platypilloid. Okay? Gynecoid, female type of pelvis. Helps in normal delivery. Android, male type of pelvis. Difficulty in delivery. Okay? Platypilloid, anthropoid, primate. Anthropoid means primate, resembling the ape man. That type of pelvis. Again, difficulty in delivery. These 4 types of pelvis they are going to ask. One student only told me, that is why I included that one in the PowerPoint. So you have to remember the 4 types of pelvis. Normal one is gynecoid. Gynecoid means female type of pelvis. All are not equal, all are not same, nothing to hide. So male type of pelvis will be there for female, male type. Is it clear? So please remember that. Then that is when you go to the clinics. When you are here, we will ask, identify the bone kept. Give 2 reasons for your identification. Bone kept is bony pelvis. Don't write pelvis. You have to write bony pelvis. Okay? Give 2 points for your identification. Now, identify the sex of the bone kept. Sex. Male or female pelvis you have to identify, whether it is pelvis of the bony pelvis of the male or bony pelvis of the female. How will you identify that? You have to go look at, this is not the normal one. Here I have to do some tactics to show whether it is in males how it will be and in females how it will be. In males, the subpubic angle, this is the subpubic angle. It is acute, less than 90. In book it may be given less than 60 in case of males. In case of females, it is obtuse, more than 90. Okay, that too in multiparous, given birth to more than one multiparous, it will be more, acute, more obtuse. Is it clear? Is it clear? So subpubic angle you have to see. Okay, that is one. Second, the obturator foramen. Obturator foramen is triangular in shape in case of in the pelvis of the females. Triangular in shape. Somewhat oval in the pelvis of males. In the male pelvis. Is it clear? In the class I was telling about obturator foramen and obturator canal. They are different. Obturator foramen and obturator canal are different. The obturator foramen, this is obturator foramen which is closed by, this is the obturator foramen which is closed by the obturator membrane. Closed by the obturator membrane. Is it clear? But anterolaterally you can see a gap. Anterolaterally there will be a gap, that is the obturator canal. Is it clear? So these type of questions they will ask when you go to the clinic. So this is the obturator foramen closed by the obturator membrane except superolaterally where there is a gap, through which the pelvis communicates with the adductor compartment of the thigh. So that is called as obturator canal. Obturator canal. Is it clear? That is obturator canal. Is it clear? Okay. So please remember that. So obturator canal is triangular in shape in the pelvis of female. It is oval in shape in the pelvis of male. Clear? Any doubt? You want to ask something? No, yourself.
No,
No, I don't know. Some network problem, I think. No, okay. Then pre-auricular sulcus. Pre-auricular sulcus. This is the auricular area, isn't it? This is the articular surface. That's the articular surface here. Articular surface here. Okay. In front of the articular surface, there will be a sulcus called as pre-auricular sulcus. There will be a sulcus called as pre-auricular sulcus. More prominent in the pelvis of females. Pre-auricular sulcus is more prominent in the pelvis of females when compared to the males. Clear? Then acetabular fossa. Acetabular fossa is bigger, okay, wider in case of the males. Females it is smaller, acetabular fossa. All bony prominences, bony landmarks are prominent in the pelvis of male and less prominent in the pelvis of female. Weight, it is more in the pelvis of male and less in the pelvis of female. Is it clear? Okay, so these are some of the important points. And pelvic cavity is deep in the male and shallow, somewhat less deep in case of female. Okay, somewhat circular in the female, oval in case of male. All diameters are more. All diameters of the pelvic inlet are more in case of female, less in case of male. Pelvis of the male. Is it clear? See, these are some of the important points. And one more thing, this one is the greater sciatic notch. Greater sciatic notch. This is the lesser sciatic notch. This is the ischial spine, converted into foramen by the sacrotuberous and sacrospinous ligaments. Sacrotuberous and sacrospinous ligaments. Is it clear? So please read that table with the bone. You will understand better. Is it clear? Okay, if there is any doubt, you ask me in the next class. This one, patella is not there. Patella. Okay. This one, if you take DM ortho, they will ask you, in fact, last time, here, when the exam was here, Professor Ali, he asked to hold the bone in anatomical position. How will you hold them? How will you hold the femur in anatomical position? Anyone? How will you hold the femur in anatomical position? You can hold?
What?
How will you hold the femur in anatomical position?
They were saying that you look for the line as posterior aspect. I can't remember the name of it. Wait.
That is linea aspera. Linea aspera. That is correct. This is the linea aspera. This is the so this is asked for spotters. This is the gluteal tuberosity. Gluteal tuberosity it was asked for insertion of the gluteus maximus. 1/3 of the fibers of the gluteus maximus, it is inserted to the gluteal tuberosity. 2/3 of the fibers are inserted to the iliotibial tract. So that was asked for the spotters. Okay, that's the gluteal tuberosity. This is the head of the femur. This is the fovea capitis, which serves for the attachment of ligament of the head of the femur. This is the greater trochanter. This is the lesser trochanter. Okay, and this is the adductor tubercle. Can you see that? That's what I was telling today about the surface marking of patella corporanji. Patella. Surface marking of the femoral artery. I was talking about the surface marking of the femoral artery. I said thigh should be abducted and laterally rotated. Take the midpoint of the, mid-inguinal point, 1 point. Second point at the adductor tubercle, I said. Connect these 2 points by a vertical line. That is the upper 2/3 of the line corresponds to the femoral artery. That's what I said in the class. Please remember that. So this is the adductor tubercle. Okay. Then anatomical position, you are supposed to hold it like this. This is the anatomical position of the femur. Anatomical position of the femur. This is how you are supposed to hold, and this is how it stands in the body. Is it clear? That's clear, isn't it? Please remember, that's anatomical position. Then, again only for DM ortho, not for now, DM ortho, those who are interested. Can you see the femur? It is convexity forwards, isn't it? Convexity forwards. Why it is so? Have you thought of it? Convexity forwards. Convexity forwards. When the child starts crawling, okay, then slowly it will start standing, then starts walking. The weight gets transmitted from the trunk or upper part of the body to the lower limb. So when the weight gets transmitted, slightly convexity will appear. Slight convexity will appear because the bone is not fully ossified. It is still cartilaginous. Is it clear? Still cartilaginous. That's why it becomes slightly bent. Sorry. Is it clear? Okay. So please remember that. Then ossification. I did write in the PowerPoint. Ossification you have to remember for the lower end, which is medico-legally important. Medico-legally important. For the lower end, the secondary ossification center. For the lower end, secondary ossification center appears at 9th month. 9th month. When I say 9th month, you may ask if the child is born 9 months and 1 week, how can it be secondary? Correct? It becomes primary if it is in intrauterine life. But usually it will be, child will be born before 9, 1 or 2 days before 9 only usually. Okay, if it is late, the secondary center may also appear little bit late, 5 to 10 days late. In other words, instead of arguing for the exact date, you should remember the child has finished 9 months of intrauterine life. Means child is viable. It was viable. So when it comes to death of the child, if the child is born dead, you can look for the month. So child was viable, but it was killed. Or you have to look for any other abnormality. So when it comes to medico-legal aspect, it is very, very important. Is it clear? Lower end of the femur. Please remember that. Forensic is there for you? Yeah. Forensic, they are supposed to ask this question. Thanks, everything. Yeah. So in the exam, they will just give you like that. What is that? Which side? Identify the side. That's what I mean. For us, for you at least, I did like this. For us, they will throw like this. They will throw. What you have to tell? What do you tell about that? We are supposed to answer visual pathway. You are looking at the bone going up and coming down. Visual pathway. The action of muscles of the neck. So for you it is okay. So why did I drew like that? Why did I drew it like that? Just to show you on which surface, on which side it is landing. That is the larger lateral facet. Larger lateral facet. Lateral. Okay? So if I hold it, put it on the left side, it becomes larger medial facet, isn't it? So I have to keep it on the right side. So larger lateral facet laterally, smaller medial facet medially. So this is of the right side. Okay? This is the apex, this is the base. This is the apex, somewhat pointed, this is the base. This is the lateral border, medial border. And this one is the articular surface, larger lateral, larger articular facet on the lateral aspect, smaller articular facet on the medial aspect. Is it clear? So by that you should be able to identify the bone. Please remember it is the largest sesamoid bone developing the tendon of quadriceps femoris. Quadriceps femoris. Quadriceps femoris. Is it clear? Okay. So rest features of sesamoid bone I have told in the last class, I think it must be there in the PowerPoint slide also. All the features. No periosteum, no medullary cavity, no Haversian system, no primary center of ossification, no nutrient foramen. Everything I told in the last class. Okay? Please see that. Is it clear? So that is about the bone. Next, coming to the muscles. Next, coming to the muscles. Shall I show the structures mainly so that it becomes easier for you and easier for me to finish off? Good. At least one student is supporting me. Can I get that? Nivita. Now, this is the femoral triangle. Why I asked for this one? Because, can you see the femoral triangle? Can you see that? Very clear, isn't it? That is a femoral triangle. This is the femoral triangle. Okay? It is bounded by medially by medial border of the adductor longus, laterally by medial border of sartorius. Base is formed by inguinal ligament, that is inguinal ligament. Apex is formed by overlapping of medial and lateral boundaries. Roof is formed by skin, superficial fascia with its contents, and fascia lata. I said superficial fascia with its contents. What I mean is it contains cutaneous nerves, cutaneous vessels, and inguinal group of lymph nodes. So that is the roof. Skin, superficial fascia with its contents, and fascia lata. The floor is formed by adductor longus, pectineus, and this one is iliopsoas. If you see inside here, this muscle, the one which I am pointing, that is the psoas major. The one I am pointing is psoas major, and this one is iliacus muscle. Lateral one is iliacus or iliacus, and medial one is psoas major. Can you see that? Psoas major. Why I am telling? Because in the gutter, muscular gutter, between the two muscles, we have the femoral nerve. Is it clear? Okay. So that is about the boundaries of the femoral triangle. Now, if you see the same thing here, this is the adductor longus. This is the adductor longus muscle. So medially bounded by the medial border of adductor longus, laterally bounded by medial border of sartorius, base by the inguinal ligament. It is not there. Inguinal ligament. Apex is formed by overlapping of medial and lateral boundaries. Is it clear? A roof, skin, superficial fascia with its contents and deep fascia, and floor. You can see adductor longus. This is the pectineus. This is the psoas major. Can you see that? Psoas major, and this is the iliacus. Psoas major and iliacus. Okay. So those are the structures which form the floor of the triangle. Now, what are the contents? Femoral artery. Can you see that? Femoral artery. Okay, with its branches. Femoral vein with its tributaries. Femoral nerve with its branches. Femoral branch of genitofemoral nerve. Femoral pad of patch. Deep inguinal group of lymph nodes. They are the contents of the femoral triangle. Clear? Now, the femoral nerve. If you look at the femoral nerve, this one is the profunda femoral artery, and this one is the profunda brachii artery. This is the medial circumflex femoral artery. These are the superficial branches. All branches are not there. You can see one branch here, one branch here. Okay, it is not clear. Now this is the femoral nerve. This is what I said, maybe ask for spotters. Identify the tie structure. Femoral nerve. Give its root value. I said it originates from when I say, okay, my mistake, write the root value specifically, perfectly, correctly. Give the root value, specific root value of the tight structure. Dorsal division of ventral rami. Dorsal division of ventral rami of second, third, fourth lumbar spinal nerves. Lumbar spinal nerves. Is it clear? That is how you are supposed to write. Now if you look at here, this one is a psoas major. When I was explaining, telling in the class today, I said along the lateral border of the psoas major, we have the femoral nerve. That's a femoral nerve. And along the medial aspect of the psoas major is the obturator nerve, which is cut. Obturator nerve, which is cut. Can you see that? Can you see the obturator nerve, which is cut? So along the medial aspect is the obturator nerve. Along the lateral aspect is the femoral nerve. Okay. And this one is the lumbosacral trunk. That is a lumbosacral trunk, and this one, please note this one. Please note that the one which is in the forceps. Identify the tie structure. Give the specific name of the tie structure. Identify the tie structure, that is fourth lumbar spinal nerve. Specific name I told in the class, nervus furcalis. Nervus furcalis. This is the one which is taking part in the formation of lumbar as well as sacral plexus. Sacral plexus. That's clear? Okay. So that is the nervus furcalis. Fourth lumbar. This is the fifth lumbar. This is the fifth lumbar. Okay. And this is the obturator nerve. Obturator nerve. Again for the spot test it can be asked. Obturator nerve. And this is the femoral nerve. That is the femoral nerve. Okay, and this is the lateral cutaneous nerve of the thigh. Lateral cutaneous nerve of the thigh. Lateral cutaneous nerve of the thigh. Please see, lateral cutaneous nerve of the thigh. Is it clear? Okay. Now that is about the nerve. Femoral artery, I said it enters the thigh in the midinguinal point. I did tell what is midinguinal point and what is midpoint of the inguinal ligament. Midpoint of the inguinal ligament is the midpoint between the anterior superior iliac spine and pubic tubercle. Okay, midinguinal point is the midpoint between the anterior superior iliac spine and pubic symphysis. There is a pubic symphysis midline, pubic symphysis and anterior superior iliac spine. Take the midpoint. That is the midpoint of the midinguinal point. That is the midinguinal point. Is it clear? That is clear, no? If there is any doubt, please ask me. Okay. So it enters the femoral artery, enters the femoral triangle at the midinguinal point, runs almost vertically down, disappears from the triangle by passing through the apex to enter the subsartorial canal or adductor canal. Just remember, it is a continuation of external iliac artery. And branches, as I said in the class, branches may not be seen. Identify the tie structure, femoral artery, name its deep branches. Deep branches, I said, deep external pudendal, profunda femoris artery, muscular branches. Superficial branches, superficial external pudendal, superficial circumflex iliac, and superficial epigastric. Okay, so those branches you have to remember, and that is about the femoral artery. Femoral vein, that's a femoral vein. That's a femoral vein, which you have to remember. Okay, this is the femoral vein, and this one is the great saphenous vein. This one, that's the great saphenous vein. That's the great saphenous vein. So, great saphenous vein is definitely one of the important questions for spotters. Identify the tie structure, great saphenous vein, where it is formed, or give its formation and name any two tributaries. Formation, it is formed along the medial end of the dorsal venous arch. The medial end of the dorsal venous arch unites with medial marginal vein to form the great saphenous vein. The tributaries of great saphenous vein, I said at least 4 tributaries you can remember, which are present in relation to the saphenous opening, that is superficial epigastric, superficial circumflex iliac, superficial external pudendal, deep external pudendal. They are the tributaries of great saphenous vein at its termination. Okay, and clinical significance I did tell, which we may not ask now, very important when you go to clinics. Please remember that slide. I did tell in the class, those who attended the class. Those are not attended, fine. Okay? Because some of the face I could make out not attended. I can make out. You are there, don't worry. I saw you sitting. Okay. Those who are not attended, they will not look at my face. That is as simple as that.
That would be the femoral vein because it is the femoral triangle. So would that be the femoral? Oh, is that right? Okay, I understand.
This is the femoral vein and this is the great saphenous vein.
Right.
Okay. I kept the forceps like that, I think. Correct? Correct, no?
Yeah.
I mean, I can do mistake. I'm also supposed to be a normal human being. Because it depends, okay? Okay. So that is the great saphenous vein. Okay? The other one is the femoral vein.
Yeah.
Okay. So femoral vein, I told the clinical significance, especially so in case of children as well as in case of adults, I said. Femoral artery, clinical significance, I have told. Please read that, otherwise I'll be taking a lot of time. The muscles. The muscles include, this is the sartorius. You can see it's the longest muscle. Some books do tell it is of the length of vas deferens, the length of the spinal cord, the length of the femur, almost 45 centimeters. Almost, not exactly 40 to 45 centimeters. It is quite long. Is it clear? So when I say long, because it is taking origin at one point in getting inserted in another point. That's why it is longest muscle. Is it clear? So I did tell the other name, Chayler's muscle. Origin, insertion, nursical action, please read. This is the rectus femoris. This is the rectus femoris. It consists of two heads, reflected head and straight head. Reflected head and straight head. Please see that. This is the vastus medialis. Vastus medialis. This is the vastus lateralis. Between the two and behind, this is the vastus intermedius. Can you see this? Can you see this? Vastus intermedius. This is vastus intermedius. This is vastus medialis. This is vastus lateralis. This is rectus femoris. All the tendons, all the muscles, they form a tendon. Okay? They form a tendon called as tendon of quadriceps femoris. Quadriceps femoris, and get attached to the base of the patella, mainly rectus femoris, vastus intermedius, vastus lateralis on the lateral aspect of the base, and lateral border, vastus medialis, medial aspect of the base and medial border of the patella. Is it clear? Extending from the apex of the patella, we have the ligamentum patellae. Ligamentum patellae. This one, you can see that this is the ligamentum patellae. That is the ligamentum patellae. No, it has to go. There is no other thing. It has to go. There is a space. It has to go. So you may get surprised. That is the space. It has to go like that. Okay. So that is the ligamentum patellae. Once you know, you can do like that, isn't it? If you don't know, your hand palm will become hurt. So that is the ligamentum patellae, degenerated tendon of quadriceps femoris muscle. Ligamentum patellae morphology, degenerated part of quadriceps femoris muscle. Ligamentum patellae. Okay. So that is about the muscles here. Let me tell about this one. The deep fascia, saphenous opening you cannot see here. Okay. The femoral ring, femoral canal, those things you cannot see here. Better appreciate that one in the picture. Only when it comes to hernia, you have to tell the coverings. The coverings you may not appreciate in the patient also. Can you appreciate the extraperitoneal fatty tissue? May not be. Anterior wall of the femoral sheath, may not be able to appreciate. Okay? And cribriform fascia, you may not be able to appreciate. Is it clear? So, but still these are the coverings, because step by step we have to tell from inside to outside. Okay? So femoral ring, femoral canal, the contents of femoral canal, all those things, please read for MCQ or EMQ. Okay? Not for spotters. And the fascia lata, I said, laterally it is thickened to form iliotibial tract. This one is the iliotibial tract. This is the iliotibial tract. I said, getting attached to the iliotibial tract, we have two muscles. This one is tensor fasciae latae. You can see the muscle there, isn't it? Can you see the muscle here? Tensor fasciae latae, and you can see the gluteus maximus getting attached. Gluteus maximus and tensor fasciae latae are attached to iliotibial tract. This is the iliotibial tract. I did tell it can be asked for the spotters. Okay, identify the pin structure or tight structure. It will be full. Okay, that's iliotibial tract. Name the muscles attached to it. 2 muscles. Okay, so that is iliotibial tract. That's about the extensor compartment. Medial compartment. Medial or flexor compartment. Medial or flexor. Sorry, adductor. Medial or adductor compartment. That is the gracilis. Look at here, gracilis, and this one is sartorius, I said. Sartorius, that is the gracilis. Okay. Adductor longus, that is adductor longus. This is the pectineus. That is the pectineus. Can you see that? Pectineus, adductor longus. Adductor brevis, can you see that? Adductor brevis. Then this is the adductor magnus. Okay. Here it is looks like continuous but not continuous. See that? Let me separate. So this is the pectineus. This is the pectineus. This is the adductor longus. Behind is the adductor brevis. Did you see? Because when I am separating, they are thinking I am separating the muscle, same muscle, but it is different. See the gap. So this is the pectineus, adductor brevis, adductor longus, adductor magnus. Is that clear? Okay. And that is the gracilis. Adductor longus supplied by anterior division of obturator. Gracilis supplied by anterior division of obturator. I said mandibular. No, obturator. Okay. Anterior division of obturator. Adductor brevis may be by anterior division, if not by anterior division, posterior division of obturator. Okay. Pectineus and adductor magnus, posterior division of obturator. Is it clear? So that is the nerve supply. And this one I just forgot, I think, in the class today to tell. If you look at here, can you see the 3 tendons? I should have told that in the class. I think I did not write in the PowerPoint also. Then I remember now. Can you see 3 tendons getting attached at one point? 3 tendons. Sartorius, gracilis, semitendinosus. They are coming from, if you look at the origin of these 3 muscles, from the 3 parts of the hip bone. Taking origin from the ilium, we have the sartorius. Taking origin from the pubis, we have the gracilis. Taking origin from the ischium, we have the semitendinosus. So 3 tendons, 3 muscles, taking origin from 3 parts of the hip bone, getting inserted at one point. So that is called as, these 3 muscles together, they are called as guy ropes. G-U-Y, guy ropes, R-O-P-E-S. Okay, guy ropes. They support the pelvis from below. You must have seen the pot which is hung by the